Hello everyone, in this video I'll be talking about morphology of root canal system part 1 and part 2 will be discussed in next video. When we look at the components of root canal system, the entire space in the dentin where the pulp is housed is called as the root canal system. And the outline of these systems corresponds to the external contour of the tooth. However, factors such as physiologic aging, pathosis and occlusion all potentially modify its dimension through the production of secondary and tertiary dentin and cementum. The root canal system is divided into two portions, the pulp chamber located in the anatomic crown of the tooth and the pulp or root canals found in the anatomic root. Other features are pulp horn, accessory, lateral and furcation canals, canal orifices, apical deltas and apical foramina. A root canal begins as a funnel-shaped canal orifice, generally at or just apical to the cervical line, and ends at the apical foramen, which opens onto the root surface at or within 3 mm from the center of the root apex, as you can see in the picture, and it resembles a cone-shaped glass. Talking about the accessory canal, it is basically entrapment of periodontal ligament vessels in the heart with epithelial root sheath, and it contains connective tissues, vessel, and it has less supply of collateral source of blood flow. So the question may come, in which portion of the root canal you will have maximum amount of accessory canal? So 74% is found in apical third, 11% is found in middle third, and 15% is found in cervical third. Going into more detail about the accessory canal and furcation canal in relation to mandibular first molar, in 13% a single furcation canal extends from the pulp chamber to the intraradicular region. In 23% a lateral canal extends from the coronal third of the major root canal to the furcation region, in which 80% extend from the distal root canal. Only about 10% have both lateral and furcation canal. So this data can come as a MCQ question in different exams. Looking at the canal configuration, Wien in the year 1969 and 1982 proposed 4 types of canal configuration. In the year 1969, there was only 3 types of classification. Later on, it was modified and one more type of classification was added in the year 1982. So the question may come, how many types? That is 4 types. So when you look at the classification, we have type 1, type 2, type 3 and type 4. And if you have difficulty in learning that, I have a mnemonics for you all. IY2 inverted Y. I, that is a type 1, a single canal from the pulp chamber to the apex. Y, that is type 2, 2 separate canals leaving the chamber but merging short of canal terminus to form a single canal. 2, that is type 3, 2 distinct canals from the pulp chamber to the canal terminus. And inverted Y, that is type 4, a single canal leaving the chamber and dividing into 2 separate canals at the canal terminus. So you have to remember IY2 inverted Y whenever you have difficulty in learning the configuration. But the question which is asked is, which is the most difficult to treat in Wien's classification? Which type? And type 4 is most difficult to treat. Later on, Bertucci classified 8 types of canal configuration. So the question is asked, how many types? That is 8 types. And it is asked in a short essay type of question as well as VIVA in MCQs. So it is very difficult to remember all 8 types, but when you remember type 1 and type 2, that is similar to Wien, and type 4 and type 8, that is very easy to remember, 2, 2 and 3, 3. But the most commonly asked question is, the only tooth that showed all 8 possible configuration is maxillary second premolar. So in this slide, you have to remember how many types, 8 types, and which tooth has maximum possible configuration is maxillary second premolar. Later on, Gulabiwala in the year 2001 and 2002 added 5 more types of configuration. So this can also come as an MCQ question. How many types were added? That is 5 types. Now the most interesting fact, does gender plays role in determining the canal morphology? So few authors, they found that in relation to mandibular first premolar and second premolar, most of the varied presentation in mandibular first premolar were found in female, and the varied presentation of mandibular second premolar was found in male. So you can remember ladies first, gentlemen second. So all the varied presentation in mandibular first premolar are found in ladies, that is in female, and all the varied presentation in mandibular second premolar are found in male, that is gentlemen. Racial group, compared with the Caucasian patient, African race have higher number of extra canal in both mandibular first and mandibular second premolar, And regarding the C-shaped canal, Asian population, Mongoloid race, and the tooth most commonly involved is second molar. So these all are the MCQs which is asked in different types of exams. Now few interesting and clinical tips for all of us. If only one canal is present, it is usually located in the center of the access preparation. If two orifices very close to each other, then there is a high chance the canal join at some point in the body of the root. As the distance between the orifice in a root increases, the greater the chance is that canal will separate. Two things to remember. If they are very close, they will join at some time. If they are placed far, they will be having a separate exit. If the first file inserted into the distal canal of mandibular molar points either to the buccal or to the lingual aspect, the clinician should think that there is a second canal. And if two canals are present, they will be smaller than the single canal. Whenever a root contains two canals that join to form one, palatal canal generally is the one with direct access to the apex. So in that case, you can prepare and obturate the palatal canal, and for the other canal, the buccal canal, you can prepare it where it meets, that is the point of the junction. And few authors, they have proposed H type of configuration. In that case, you have to modify the access preparation so that you can prepare till the apex and will have a separate exit, as you can see in the picture. Angle radiograph is always needed for tracing out the number of roots and canal. So how many radiographs? So if you take 2 to 3 angle radiograph, that is sufficient. And if you are still confused, you can take CBCT for greater sensitivity, but only when you are in suspicion. In all the cases, we don't use CBCT. And there is one more fact, that is abrupt disappearance of large canal in the mandibular premolar usually signifies a canal bifurcation. So when you trace in the canal that there is the radiolucency is disappeared, then you should always think that there is a canal bifurcation. So this is how we end up with the morphology of root canal system. In the next video, I'll be talking about the morphology of apical portion of root canal system. So if you have any MCQs, if you have any questions, if you have any suggestions, please write in the comment section. I'll be answering that. Thank you very much.